my pleasure and honor to present the next speaker, Professor Jacob Sosna, who is Chief of Radiology in Hadassah Medical Center and also the Chairman of the Israeli Radiological Association. And he will speak about dual energy imaging in abdominal applications.
Good morning, and before I start, I'd like first of all to thank the organizers for organizing this conference for the ninth time, and especially Dr. Laurence Baleish. And it's not an easy task, and we appreciate that you do it continuously. And it's an important event in this year, having so many people coming to Tel Aviv and learning and listening to what's going on. So please join me in thanking you. I will speak about, not about MR, but about CT and about abdominal and novel applications of CT. And CT is not complicated. CT is based on density. And as we all know, CT today is all based about Hounsfield units, and we have the different Hounsfield units and the different tissues, but the relative changes between the different organs are quite small. We have the kidney, pancreas, blood, and liver, and they are very similar, ranging from 20 to 70 or 80, but different elements can have the same CT numbers. When we think about visualization in CT, so we have axial images, coronal sagittal, we have very nice reconstructions, volume rendering, and VIPs, and that's the way we're used to look at CTs, and we can have very fancy 3D reconstructions. Currently, we can have 3D printing that we can actually touch the organs, but we do have a lot of challenges, and some of these can be overcome by spectral CT or dual energy CT. So we have issues with the selection of the right protocol, the injection of contrast, the timing of scanning, tissue contrast and visualization, characterization, and we have also a lot of artifacts. So let's speak about spectral CT or dual energy CT, and I believe it's a different dimension in modern CT. So there are different approaches in dual energy CT. We have Siemens introduced a few years ago the two tubes that are rotating around the patient in different energy. GE has again a tube-based technique in which we have rapid KV switching ranging from 80 to 140 and very rapid change. Philips introduced the dual Detector approach, the sandwich, which is detector-based, and we have Toshiba. They claim that they have dual energy, but actually it's a full rotation around the patient that needs to be done twice in different energies. So just schematically, the dual source, two tubes around the patient, rapid KV switching, we have different energies, 80 and 140 kVp alternating, the dual spin, which is the full rotation around the patient, and the dual layer, which is two detectors, one above the other. One absorbs the low energy photons and the other one the higher energy photons, and we split the energy into two energies, and this is filtrated before they reach the patient. So again, schematic representation of the current technologies, the detector-based and tube-based. This is the two tubes, and this is the rapid KV switching. And we have new terminology. Until now, we didn't have a lot of changes in the way we looked at CT, but now we have mono-E images, scatter plots, VNC, iodine maps, effective Z. I believe we call it MRization of CT. We have many sequences. We were not used to look at so many when we started looking at CT. So this is a representation of how we get the images. So the inner and outer layer, we absorb 50% at the low and high energy, and we generate the images. And what do we do after that? So we have an attenuation map of the low energy and the high energy. We reconstruct them, and we have a few sets of images. That's the combined, the regular image, the way that we are used to look at the images. The different mono-E, it's the virtual images that would simulate the way the images would look at 40 keV, 50, 60, ranging to up to 200. And then we can manipulate iodine. We can look at iodine concentration maps on one hand, or we can delete iodine. So we do some manipulation of the iodine, and this is all based on physical principles. When we go down with the energy of the photon, and if we go down from 140, let's say, to 20, different tissues behave in a different way. If we look at iodine, when we go down, it goes up, and calcium, again, when we go down with energy, the attenuation goes up, but in a different way, and we can separate iodine and calcium. On the other hand, if we look at fat, at lower energy, fat it has lower Harms field unit, and therefore we can use those changes to quantify and to select the images according to the material that we have. So this is the same image seen in different KEVs. That's the low KEV 50, and this is 140. It's the same slice. So we can see the portal vein, we can see the pancreas, we can see the vein with higher attenuation. And when we go up, we see less attenuation, and we see probably less artifact. So instead of calling it regular windowing, as we are used to say in regular CT, we have spectral windowing, enabling us to see different elements when we change and scroll in with different KEVs. So currently, we read CT of the conventional images, but maybe monoenergetic images may increase the signal and decrease noise. So maybe we can switch to reading of the KEV-based imaging. And we looked at some cases. We compared conventional CTs to 75 KEV mono images, and we can see very similar numbers of the aorta and the liver. And we quantified a set of patients, and we saw that the mono images are better, or markedly better in 83%, better in 10%, and equivalent in 2. And maybe, that's a speculation, maybe we can switch now to reading of the monoenergetic images and get better images with less noise. We can also look at the spectral attenuation curve, and I'm showing this example. If we look at the aorta, that's this green circle. When we go down with the energy, it goes up. Fluid in the stomach stays the same, and if we look at those curves, we can differentiate different tissues. Of course, here it's easy, it's iodine and water, but we can see the different tissues and actually improve our diagnosis. Since we can separate iodine and calcium, we can delete iodine or show only iodine. So if we look at the HU value at high energy and low energy, calcium and iodine behave in a different way. We can put a line in between them, and then we can see iodine in the aorta and calcium in the bone, and then we can delete the iodine from the image and get a VNC image, which is a virtual non-contrast images, which enable us maybe to save patient radiation by not scanning the patient with true non-contrast images. And again, an image without iodine, with iodine, and with the VNC. They are getting better, they are not perfect, the VNC images. We can sometimes delete stones from those images, so that's why we didn't shift totally to VNC images. Another example, we have a few white dots, we don't know, are all blood vessels. That's the VNC, we can see that's a granuloma, and all of those areas are blood vessels based on this image, and we can see it in the lung windows as well. So let's go back to our challenges and start with the issue of protocol selection. I don't know how many of you have dual energy scanners, but if you use the Q tubes, you need to decide in advance whether you use the dual energy, because you need to decide if to use 80 and 140 kVp in each tube, and this needs to be pre-selected. When we use the dual energy mode of the rapid KV switching, again, we need to start to decide in advance that we want to use dual energy. And but if we use detector-based, and then also in the future photon counting, we may select the protocol retrospectively, because the data is always there. The decision to review spectral data can be made following the review of the images, and they resemble the regular CT image. So we evaluate 43 cases at Hadassah, and we looked in how many cases did we use spectral tools. And most centers that use dual energy use it in a very small minority of patients, maybe 5–10% of cases. If somebody is very interested in the technique, it may use it in a higher proportion. We used it in 72% of cases because we could use it retrospectively. We have the Philips dual energy scanner, and we use it for lesion characterization, for stones, vessel patency, and these are some of the tools that were used. The most frequently used tools were monoenergetic images, then iodine images, effective Z, and virtual non-contrast, which is again deleting iodine from the images. And a few examples. That's a case of a 36-year-old female with insulinoma. In this case, we would have prescribed dual energy in advance because we knew that she might have insulinoma. So we can see the lesion over here in the conventional image. At the 55 keV, we can see the lesion better contrast and better lesion differentiation. But on the other hand, that's a 32-year-old male with abdominal pain. We see a tip stent, but the regular image shows us blooming artifact. But if we use the iodine map, we can see that the stent is open with some intimal hyperplasia, but there is flow inside. Just on the combined image, even changing the window wouldn't help in getting to this diagnosis. Another case of showing the SMA, and here we see the SMA with blooming artifact. With the iodine image, we can see the flow, and in this case, it was a patient with ischemia with some bowel necrosis and perforation, and we could evaluate the blood vessels adjacent to it. That's an 88-year-old female that presented with fever, and incidental P was detected. We can barely see it on the combined image, but we see it to a much better degree at the 55 keV monoenergetic images. So in those cases, one can use dual energy to improve the confidence and also to achieve better diagnosis. And a case of a DVT seen in this 22-year-old male, but with the low KEV and the iodine map, we can see it much better. Let's move now to the injection of contrast and the timing of scanning. As we all know, CT angiography are not always perfect. In about 10–15%, we get suboptimal studies, and in this case, dual energy can help us. So that's the conventional image, which is not bad, but we can improve it with seeing the low KEV images, getting a better CTA, and here seeing only the iodine map. And that's an example of a supposedly CTA study. It was unaccepted. We called the patient back and we repeated the study, and that's a much better CTA. And we couldn't use the KEV because of our IRB regulation at this time. So, but we looked back at the data and we looked at the 50 keV, and the images are similar. So potentially by using the low KEV, we could save the patient's repeated studies and see much better images. And in this case, it's a 120 kV regular image. The count field unit is 227. Just by looking at the 55 kV, we can increase the count field unit to almost 400 and get an image that is much better, and again showing us an SMA, and at the 50 kV we have increased conspicuity and attenuation of the SMA, and also in the liver parenchyma, and also seeing the liver vessels. So if we can see contrast better, so why we can't decrease the dose of iodine? And this is something that is being used, and this is a case given to me by Mass General. So we see a suboptimal study, and then we use, we can see in this image at 60 kV, a very good image, and we injected only 35 cc's of contrast. So we can go down very significantly with the dose, and especially in patients that are diabetic and have kidney function, we can decrease the dose to about 1/3 of the regular dose that is used. And we wanted to evaluate it in, we did a phantom study to see whether it works. So we wanted to determine the value of dual energy CT using very low iodine concentration for the detection of thrombus in an in vitro phantom model. And we used tubes. We took some blood from swine. We formed thrombus inside those tubes, and we filled them with contrast that is very diluted. And we looked at the different concentrations, and we did a preliminary study. We took count field unit threshold of 100, and we wanted the contrast to be in conventional images up to 100, which is very low. Because a good CTA should be more than 200. But we decided that we want to look at 100 and see whether dual energy helped us. And we graded the images. So we looked at the images that are small on purpose, just to simulate the way that we looked at images. This can be an SMA, or it can be a pulmonary artery. So in this case, there is a definitely filling defect, and the images is good. Here there is no thrombus, and over here, maybe yes, maybe no. We don't know, and we judged the images. So if the images were good, the sensitivity and specificity were very high, 97, 99. And if the images were poor or fair, the sensitivity and specificity went down to 78 and 90. They were still good. But if we look at what percentage did we have bad images, poor images or poor images, so at 40 and 50 there were no poor images, and it went up to a significant number at the 180 kV, meaning that we should look at the 40 and 50 kV. If we look at the accuracy, we can see that with 40 and 50 kV, sensitivity and specificity were perfect, and when we go up to 100 kV, it comes down with sensitivity and specificity. So the results imply that dual energy scanning can permit reduced contrast dose while maintaining or even increasing reader confidence, which is important. Right now we are checking even lower doses, going down to about 50 Hz per unit, and checking the results. And this can be applied to CT angiography, venography, urography, whatever we want to use and see the contrast. And we have a very frequent problem with diabetic patients that we need to do a runoff to look at the blood vessels in the abdomen and the lower legs. We hospitalize them, they get hydration. It takes 7 hours before and 7 hours after. But if we can decrease the dose to 10, 15 cc's of contrast, it makes a big difference. Let's move now to tissue contrast and visualization. That's a conventional image of the pancreas, but at 50 kV, the contrast between the pathological area and normal pancreas is increased, And even if we look at conventional or anatomical structures, we can see the pancreatic duct over here, but at the 65 keV, the pancreatic duct is seen to a better degree. And we can see CT enterography studies and CT urography studies, in this case at 140 keV, because of this concentrated iodine. If we go up, we can see better delineation and better visualization of the bowel loops. Or if we look at the kidneys, in this case, we can see an obstructed kidney and the corticomedullary differentiation that is improved with low KEV. And different examples of the kidneys looking at this cyst, that's a conventional and 60 keV, and we see improved contrast and improved signal to noise in those images. If we move to oncology, if we look at the left-hand side, we see a few metastases, one here, and maybe one here, but if you look at the low KV, we can see that there are more. So the question is, now in oncology follow-up, what, when we evaluate what KEV or what image should we use, and this may be important, and also for the measurements. If we measure this lesion, it's 53 by 56 millimeters. At the 55 keV, it's 51, almost by 52. So there are differences. So we need to be precise and state at what keV, at what phase did we make the lesions, because some changes may be only technical and not real when we scan those patients. When we look at vessel patency, we see a very calcified SMA. If we look at the conventional bone windows and we try to play with it, it doesn't help us much. But if we look at the iodine maps, we can see that there is some flow and there is less blooming artifacts, and we can see it again in this coronal projection, the conventional, and the iodine map showing us the flow within the SMA. And we can also look at the numbers match. If we all hear about beam hardening, so let's look what is beam hardening. This is the SMA before the stent, and the average density is 197. It goes up to 250. That's not real, it's beam hardening. The HU value is higher. If we look at the iodine in milligrams, this is 9.2 milligrams, and this is 9.4 milligrams per ml, and the numbers match. So we are much more precise in quantification of iodine within those vessels by using dual energy. I will finish with two last topics, which is characterization and looking at artifacts. That's a patient that arrived with an IVC thrombus, a young patient with no prior medical history, and we wanted to evaluate whether it's a neoplastic thrombus or a benign thrombus. So we look at this scatter plot and we look at this blue circle. We can see that there is no uptake of iodine in this thrombus, so it's not a tumor thrombus. We can have the same application for liver and portal vein problems to see whether there is quantification of iodine, and not only measuring counts per unit as we are used to do. If we compare it, for instance, to this uptake, which is iodine in the bar, we can see the difference in this case. We can look at, see two lesions. One is the red circle. We can see again no uptake of iodine. The red circle, the green circle again, meaning that those are adenomas that didn't take iodine. And we can look at those lesions after contrast was injected, meaning that we don't need, if the study that was done in the ED and we didn't have a non-contrast study, we don't need to call the patient back and scan again for those applications. That's a lesion in the adrenal. Iodine-enhanced Counts per unit is about 45. We cannot decide if it's an adenoma or other mass. If it's an ED patient, we would call him back. The two-non contrast gave us 11 counts per unit. The VNC, again, 11 counts per unit. It's very precise, so we can save the patient repeated studies and added costs. We can look at stones and decide whether they are uric acid or calcium stone. It's important because uric acid goes for medical treatment and calcium-based stones go for other treatments, extracorporeal shockwave lithotripsy. So that's a soft stone. We can see two stones over here, but they are different. And in this case, we have an effective Z that is high, and it means that it's not a calcium stone. And this is a uric acid stone that gives us the ability to provide medical treatment to this patient. We can look for leaks, as this case I've shown before, looking over here this time, seeing whether there is leak, and there is increase in attenuation, meaning there is leak of contrast from bowel to this area, and help us to decide that this patient needs surgery. I will finish with a few examples about the kidneys. We have a very frequent problem. We see a lesion. We don't know whether there is uptake of iodine, if it's a high-density cyst compared to a solid lesion. Here we can see that there is no uptake of iodine, and in this case, there is uptake. This is a solid lesion, or we can look at renal cyst versus a mass. The conventional image gives us 25 Hounsfield units. It's indeterminate. The iodine is very low. It's 0.2 milligrams. The cutoff usually for enhancement is 0.8. So if it's less than 0.8, we can decide that there is no uptake of iodine in the lesion, and this is a high density or higher density cyst, and again showing an interesting case of two adenomas that behave differently. This lesion, as I said, with fat it goes down. That's a fat-rich adenoma. The other one is an adenoma with less fat. So we can also quantify the amount of fat within lesions and also within the liver, but we are not very precise in quantification compared to MRI, because the threshold of the fat or the percent of fat should be high in order for CT-based measurements to be precise. We can look at implants and see if it's a silicone compared to water. And I will finish with artifacts in the last few minutes that I have. So we all know those problems with metal hardware. We see a lot of artifacts, but with spectral windowing and changing the KEV, we can see that the image. And over here again, we have a magic glass, sliding glass from side to side. We can see the differences, and this is applicable in abdominal imaging when we have a lot of hardware, especially in the pelvis, after changing the femoral heads. And those blooming artifacts are also in blood vessels, as in this case in the neck, and we can have lower blooming artifacts. And a known problem with injections of contrast, strict artifacts from rapid injection, and with 55 or different KEVs, you can have less artifacts. I'll finish with 1 minute about the future, or maybe it's already the present, which is photon counting. In dual energy CT, we split the energy into two. In photon counting, we split the energy into different beams. So we can split the energy into 4, and then the detector counts the number of photons within each energy. So instead of having 2, we can have 4, and then we can separate different materials, and this is just showing CT in colors. It enables high spatial resolution, multiple material characterization. It's in development. I know that in France and Lyon they have a prototype of a photon counting scanner. The problem with photon counting is that you need, in order to count, it needs to be slow enough. So you can scan up to 2 millimeters in a slice. You can scan up to 100 MAS, so it's relatively low, but the images are much better. If you know, we measure resolution in line pairs per inch. In CT, it's about 10. That's the conventional. In mammography, it's more than 20. We can get, with photon counting technology to about 17 or 18. So increasing the resolution of CT in a very significant way, but it's still in development, and those are some of the images that would show how bone would look at this high resolution without increasing the dose to the patient. And we can scan different materials and see gadolinium only. And as you know, gadolinium can be seen in CT. We can have different materials and maybe have different contrast agents in the near future. So just to conclude, spectral CT offers a new dimension in everyday practice. It can help us face the challenges that we have. And I believe the transition to photon counting is on the way to take another 5 or maybe 10 years. So thank you for your attention.
Before we proceed, you have the opportunity to ask a question to Professor Sosna and to Dr. Maite Levin. Does anybody in the audience have any questions regarding dual energy or regarding diffusion used in liver imaging?
I have a question to Professor Levin. How often do you use the quantitative ADC or the quantitative measurement? Because usually what we use in clinical practice is mostly qualitative. So besides of the research arena, how often do you use it?
I use it each time, but with an only exponential approach. I mean, we will use a quantitative analysis, and after I will always check on the ADC map what is the quantitative analysis. But no, I don't report the numbers, just for me. Just another sequence to interpret the image.
Other questions from the audience? To Professor Sosna, Dr. Maite Levin?